Hello, welcome to your online lecture for the course Pathophysiology 1. In today's lecture, we're covering reproductive disorders. On this slide, you can see various different themes that we'll be covering today, so different conditions, different diseases and states. There are two on here which you'll recognize as topics we've covered already, being cervical cancer and breast cancer, but they are really grouped under the theme of reproductive disorders. We're going to begin by talking about common disorders of the female reproductive system. This slide talks about pelvic organ prolapses, and there are various different types as well as severities or degrees of prolapse. You can see uterine prolapse, a cystocele, which is prolapse of the bladder, and a rectocele, which is prolapse of the rectum. Now, inside the pelvic cavity, we have the pelvic floor, and this is made up of muscles, ligaments, connective tissue. It's really the support system. And so many estrogen-dependent organs within a female will change over time. So when there's pregnancy, a postpartum, postmenopausal, the pelvic floor can become weaker. And when it's weaker, it doesn't support the organs as well within it. And so women will describe different problems that they experience or different signs and symptoms. Commonly, women will describe that they feel this heaviness within the vaginal region. So if we look at uterine prolapse here, and just so that you know, remember anterior versus posterior, here we have the uterus. So the uterus should normally stay suspended here, but when it becomes weak, it can prolapse, meaning that it's moving downward. And so here we have first degree, second degree, and third degree prolapse. With third degree prolapse, you can see that the uterus itself, and this is the cervix here, is actually outside of the body. So it prolapses then through the vagina. And if we look at this second image here, still talking though about uterine prolapse, here's the uterus. The uterus can move downward through the vagina. So here's the vagina here. This is the bladder. This is the rectum, and it can move downward. So that's called a prolapse. When it comes to a cystocele, again, this is referring to the bladder. And here we have, again, anterior and posterior. The bladder here normally should look like this. And you can see that when urine is in the bladder, it would move nicely through the urethra and out of the body. But here we have this weakness that's caused it to bulge downward. And you can see that it's bulging into where the vagina is. And it's also changed the angulation here of the urethra. It can be difficult for urine that's within this region to properly leave the body. So it can be really a form of obstruction. You can get bacteria that hangs out and isn't excreted, or that populates in this region, that can lead to bladder infections. And then, as we know, it can ascend and infect other areas of the urinary system as well. And that's because the wall here has become weak, and so it's collapsed. In the case of a rectocele, you can see still posterior here and anterior. You can see the bladder is in good shape, the uterus as well, but the rectum has bulged inward. So the wall of the rectum that really makes up the wall of the posterior vagina has collapsed and become weak, and it collapses into the vagina. So you might be able to envision why women would experience a heavy sensation in this region because of the protrusions. Now, women can experience uterine prolapse on its own, cystocele on its own, and rectocele on its own, but there are cases where they can experience prolapse of the bladder, prolapse of the uterus, and prolapse of the rectum, which would just exacerbate their feelings and their sensations. And here you can see that defecation can be made a little bit more difficult in terms of being able to completely and properly void the bowels. And this can be corrected using sometimes what's called a pessary ring can be inserted that is essentially placed in the vagina and supports everything, supports the entire wall, but it has to be removed in cases such as intercourse, for example. And then there is surgical correction that can be done to help re-support the pelvic floor. Let's speak now about overly large ovaries. called cysts. This can commonly occur during puberty and even during menopause, because during these times there are larger changes in hormone levels. And they're referred to as benign functional cysts. Functional because it really follows the cycle. It will increase and decrease in size depending on a person's cycle and exposure to hormones. They're usually unilateral. It's usually found on one side rather than occurring on the opposite side as well. And they are oftentimes asymptomatic as well. So sometimes there'll be a finding during a pelvic ultrasound for some other reason. They may find that this individual has ovarian cysts. The most common types, as you can see here, are follicular cysts and Corpus luteum cysts, and we'll talk about those on the next slide because they are the most common. The less common types include dermoid cysts, endometriosis, we'll talk about endometriosis as well today, and ovarian torsion. Okay, so here are the two main types of ovarian cysts that we're going to discuss, the follicular and corpus luteum. And remember back to normal anatomy that the ovarian cycle has a follicular phase and a luteal phase. And remember that we have developing follicles. We'll have one that dominates, it's the mature one, and it will be released as the egg that's released at ovulation that would be searched for by sperm, should it be present. Then this that remains after ovulation will form a corpus luteum. So this is the luteal phase. And then it will slowly but surely regress and eventually become a corpus albicans if that person does not become pregnant. So most cases then of ovulation. So let's start with follicular cysts. Normally, we do have a few follicles that will start to mature within the ovary. But usually only one is going to dominate, and as I already said, that dominant one is going to be what's released during ovulation. And then the other ones that weren't the dominant ones will shrink. And if that happens normally, then there's not problems with follicular cysts. But what can happen instead in these cases is that the dominant one fails to rupture, so it remains within the ovary. So this ovulation here does not occur for this mature egg. Or what could happen is the non-dominant ones that wouldn't have been released via ovulation anyways, but should normally shrink, don't shrink. And so this buildup of these mature dominant and non-dominant follicles can occur within the ovary and cause the ovary to continue to enlarge in size. The other type of cyst is a corpus luteum cyst. Now remember that the corpus luteum is that remnant of the mature follicle after ovulation has occurred. And normally, if a woman doesn't become pregnant, as I said, it will degrade and become the corpus albicans. But with a corpus luteum cyst, the corpus luteum can begin to fill with blood, really a intracystic hemorrhage, so bleeding within the cyst that is starting to what enlarges, and then it can eventually rupture. These are less common than your follicular cysts, but they are quite painful when they rupture. Now we'll move on to a different condition called uterine leiomyomas. Now remember that leiomyoma is relating to benign tumors of smooth muscle. So this term here referring to smooth and this term referring to muscle. And these are then benign tumors of the uterus but affecting the smooth muscle. They are the most common type of benign tumor of the uterus, and they're also called uterine fibroids. Sometimes you'll hear them just called myomas, but this is probably the term that you're familiar with, whether you've experienced it yourself or you know somebody that has. And they're fairly common, affecting up to 80% of women. And if you recall, the smooth muscle of the uterus is called the myometrium. And what can happen with this condition is it can lead to pain and abnormal bleeding, but it can also put pressure on nearby structures, just like anything that's growing in size could do, even though it's benign. In terms of where they're located, well, here's the muscle, as you can see, of the uterus, and we have different layers. So it can be located in the submucosal, the intramural, or the subserosal layers. And it's usually estrogen and even progesterone dependent or sensitive, so it occurs usually then during reproductive years when these hormones are present. Risk factors include it's hereditary, so it can run in the families. In family, another risk factor is nulliparity, meaning that a female has never been pregnant. So there is a greater risk then as well during reproductive years, as already mentioned, because of the exposure to hormones such as estrogen. And then once menopause hits, they tend not to grow the same way. Now, if you have a submucosal fibroid or uterine leiomyoma, it can lead to what's called a polyp. And really a polyp is just the extension here off of the wall into the uterus. And these polyps themselves can bleed. And if there's a lot of fibroids present, then the uterus can actually expand and it can become very rigid. And so this would make implantation of a fertilized egg very difficult into the uterine wall, whether there's many or even just a few. But the other consideration too is if a female does become pregnant, you could see that if you have a growing fibroid as well as a growing baby, how that could be a problem. This slide discusses another condition that I'm sure many of you have heard of called endometriosis. And this is defined as the presence of functioning endometrial tissue, or what are sometimes referred to as implants outside of the uterus. So looking at this image, you can see all these black indicator regions that are in black, and these are conditions of endometrial tissue that is not where it's supposed to be, which is it should be just specifically within the endometrium of the uterus. And it can occur in up to 22% of women during their reproductive years, and it can cause pelvic pain, infertility. It can even lead to the formation of pelvic cysts. Sometimes it is asymptomatic in individuals, but those that it is symptomatic in addition to pain, they can have abnormal and very heavy and painful periods. They can even experience pain during urination, pain during even after urination, pain during intercourse and after intercourse. Sometimes urge incontinence and even difficulty becoming pregnant are possible complications of endometriosis. And what's interesting is these cells can actually be spread after, for example, surgery. So if a female has a C-section in order to deliver her baby, some of the endometrial tissue can be spread just from the surgery itself. There are cases where it can spread even to areas such as the belly button and sort of set up shop in that region. But in any case, this functioning endometrial tissue, depending on where it's located, it can bleed, because we know that the uterine lining bleeds. And so this bleeding can cause pain, because you're going to get bleeding into areas where blood isn't normally supposed to go. And so it can cause pain because of the buildup of blood. In terms of the infertility that I've already mentioned, inflammation, lots of inflammation can be present with this condition, as well as scarring, especially over time. And so this can impede the ability of appropriate fertilization. Now on to benign breast disease. And the best way, one of the important comments to make about this is that it can be easily confused with breast cancer because of the presence of masses. And really, you can classify benign epithelial lesions of the breast as being non-proliferative, proliferative, but also a third one would be the atypical hyperplasia that we've spoken about when we talked about breast cancer. But starting with non-proliferative, this is usually referred to as fibrocystic disease. So fibrocystic changes are seen where there's dilated ducts within the breast that are surrounded by collagen, and they can be found in multiple locations throughout the breast. Usually there's no pain associated with them, and there's also no risk of cancer development, but these lumps can be confused with a breast cancer mass, so they can put somebody in panic mode pretty quickly. Then there's also proliferative. An example would be a fibroadenoma. So this is a single benign tumor in the breast. It is estrogen dependent, so it appears premenopausal when estrogen stimulates its growth. So they can look like cancer to an individual even though they're not cancer. Now we'll move on to talking about common disorders of the male reproductive system. We'll start by talking about disorders of the scrotum, and with these 4 conditions listed here, varicose, hydrocele, orchitis, and testicular torsion, they tend to have many of the same clinical manifestations, being painful scrotal swelling and or masses within the scrotum. We'll start by talking about a varicocele, and a varicocele is common in younger adults, and it's easily repaired surgically. But what happens here is there's dilation of the testicular veins. So when you think of this term, think of varicosities that are present in other areas of the body, right? The dilation of the veins. But it can lead to infertility if it's not treated. So that's why treatment can be very successful with this condition. Hydrocele is where fluid is found between the testes and the skin, so between the layers of the tunica vaginalis. It is oftentimes congenital, meaning that babies can be born with this condition, but it can also happen in children and adults. It oftentimes, in many cases, can resolve spontaneously, so usually not a problem. Orchitis, this is acute inflammation of the testes, so the itis here refers to inflammation. And it's most commonly caused by mumps. So the virus that causes mumps that infects the parotid glands can travel to the testes and lead to inflammation, pain, as well as infertility. And so that's one of the biggest concerns of mumps in males, is that it could lead to infertility if it does make its way to the testes. Testicular torsion, this is the most severe of all of the 4 conditions listed on this slide. And with this condition, the testes rotates around itself and ends up cutting off its own blood supply. So it's considered a surgical emergency. It's common in neonates, so newborns as well as young boys. And if a parent brings their son to the emergency room or to their doctor complaining of testicular pain, it's important to consider testicular torsion, because very quickly you can end up, when the pain starts, it can be because ischemia has begun, so reduction in blood supply to certain areas of the testes, which can lead to necrosis if it's not treated. So, surgical emergency. This here shows you a different image of what each of these 4 main conditions affecting the scrotum could look like. The next condition is called Cryptorchidism, which is defined as the failure of the testes to descend into their normal final location, being the scrotum. Crypt refers to hidden, and orches refers to the testes, so they're hidden testes. Now, in embryo, the testes forms in the abdomen and then will descend through the inguinal canal. So it's really important with newborns and then, infants, is to check that their testes actually did descend into the scrotum. So they move really in this direction to their final location. Now, this condition, as mentioned, is when the testes fail to go through this proper descent. And what they can do is remain either in the abdomen, they can start their descent and then remain in the inguinal region, so they pass through the inguinal canal, or they can remain in the suprascrotal region, so just above the scrotum. Sometimes this area is referred to as the pubosacral junction, so the pubic region to the sacral region. And there are 2 types, as you can see. We have true and ectopic. I really spoke about true already in abdominal, inguinal, or suprascrotal region, where the testes remains instead of ending in the scrotum. But with the ectopic type, this is where the scrotum or the testes kind of wanders off. So you can see the various different areas that it can go instead of to its normal final location. Now, this condition of cryptorchidism can affect up to 30% of premature newborns, and only about 3 to 6 of full-term newborn males will be affected. Most, though, In most cases, the testes will descend by the first birthday just naturally, so without any intervention. But if it doesn't descend and it's left untreated, then it can lead to infertility, or at the very least, reduced fertility in these cases. And with infertility, one of the main reasons is because the testes, where sperm are produced and kept, are going to be in an environment that's too warm, which is that of inside the abdomen. So they're kept at normal body temperature, which is not good. And then the other risk is testicular cancer. So cryptorchidism can lead then to not only infertility, but the development of testicular cancer. Next up is benign prostatic hyperplasia, or BPH, which we've spoken about briefly already. But this condition is defined by hyperplasia, which we know is increase in cell number of the prostatic glands and or the connective tissue stroma. It can sometimes be confused with prostate cancer. And although it's not written on the slide, you should make note that it usually begins in the inner layers of the prostate, okay? Now the normal prostate, looking at this image, is surrounding the urethra. So we have the bladder, we have the prostate. It's dissected here so that we can see it properly. And then here's surrounding the urethra here, where urine would pass from the bladder out of the body. But with BPH, the prostate gets larger, and it can put pressure not only on the urethra, so you can see how this is narrowed here, but also on the bladder itself. And it can cause changes in the smooth muscle of the bladder and smooth muscle of the urethra, just to account for this issue. And it can lead to obstruction, which is pretty obvious that it's going to be much more difficult for urine to move from the bladder past this narrowing. Urine retention, if we can't get all the urine out of the bladder because of this obstruction, it can lead to increased chance of urinary tract infections, as well as urolithiasis, which are stony concretions in the bladder that can form over time as well, so bladder stones. And it can also lead to an enlarged bladder, because the bladder itself may need to get larger and stronger just to be able to push urine past this obstruction. And then with the UTIs, just one more thing to mention about this is that waste products can accumulate and remain in the bladder, leading to an increased chance of the development of infection. Now we'll look at reproductive cancers. So now we're talking about cancer. So the first cancer that we'll talk about is endometrial cancer, so cancer of the uterus. And the most common is an adenocarcinoma. Remember that the term carcinoma is referring to a tumor, cancerous tumor of epithelial cells, and in this case, glandular. Important risk factors include estrogen replacement therapy. So this can be given post-menopause in order to help combat some of the signs and symptoms that women experience. And this is problematic when certain organs such as the uterus are exposed to it. In addition, tamoxifen. So tamoxifen is an estrogen receptor antagonist. And when it can be sometimes given for estrogen sensitive tumors to try to stop the growth of the tumor. So for example, a female that has breast cancer might be given tamoxifen to suppress the growth, but then they have to be warned about the risk of the development of endometrial cancer. So this medication isn't used as much now because of this risk factor of increased endometrial proliferation. Nulliparity as well, so a woman that has had no children. 95% occur after menopause. And abnormal vaginal bleeding is the most common manifestation. When a woman has bleeding post-menopause, it is not good. And so you must consider cancer in these situations if a female is bleeding after menopause. Endometrial cancer is the most prevalent gynecological malignancy. If there's an early diagnosis, the 5-year survival rate is over 90%. Even late diagnosis, the 5-year survival rate is still quite good at over 60%. But remember that abnormal vaginal bleeding is a common clinical manifestation and may not be a good thing. The next cancer is ovarian cancer. They are adenocarcinomas. Okay, so affecting glandular tissue, epithelial cells. It is cancerous, but they're called cyst adenocarcinomas. And they're considered a silent disease because of their late diagnosis. These cancers can get really big, but because there's so much room in the pelvic cavity for them to expand, they can go unnoticed and undiagnosed for many years. And it's then it'd be very, very late, at which time this individual realizes that something's wrong and gets assessed. They could, at this point, have ascites. They could have a very upset stomach all the time and constipation. They have early satiety, meaning they feel full faster. They can even look like they're 6 months pregnant. But malignant ovarian tumors, they cause more death than other female reproductive cancers. Now, when they metastasize, and when they do, and it can happen because it's caught late, is the metastases is frequently peritoneal, referred to as peritoneal implants. So it's cancer cells that escape and they implant themselves, so peritoneal implants, in the peritoneum. And this is very characteristic of this cancer, and it can make it difficult to control because the implants, as you can see in this image, can be in various different regions throughout the peritoneum, so it can be sort of difficult to stay on top of it. Now on to some male cancer, starting with prostate cancer. The incidence is higher in westernized countries, as you can see up on this chart. It's highest in North America, Australia, New Zealand, and then there's a sharp drop once you get to developing countries. And so dietary factors, the so-called Western diet, may play a role with this, but hormonal factors possibly as well. Endocrine disrupting chemicals include chemicals that are in our environment that disrupt the hormones in our body. And of course, we have much exposure to this in the developed world. Prostatitis, so infections that can lead to inflammation of the prostate, may predispose somebody to prostate cancer, and it's possible too that there's an inherited genetic predisposition in up to about 10% of cases of prostate cancer. Prostate cancer comprises, at least in 2016, about 20% of new cases of cancer, and followed by colorectal and lung in males, if you remember back to our cancer charts. But the mortality from prostate cancer is only about 10%, so early detection is very important. And there is an increased risk of development of prostate cancer with age. In this image here of prostate cancer, you can see that this cancerous tumor of the prostate has invaded the rectum, part of the colon, invaded the colon and invaded the bladder. And what this can do is lead to blood in the stool as well as blood in the urine. A little bit more on prostate cancers. Just like many cancers, it is an adenocarcinoma, and it starts in the periphery of the prostate. So that's different than what we spoke about with benign prostatic hyperplasia. And prostate cancer grows very slowly, and because of its slow growth, sometimes it's monitored rather than operated on immediately. Because prostate surgery has been linked with some other disorders such as urinary incontinence, and it would make sense if you think of the proximity of the prostate to urinary, part of our urinary system organs, but also erectile dysfunction for the same reason. So sometimes a watch and see approach is taken along with certain therapies. Clinical manifestations, or the signs, symptoms, evidence of prostate cancer, are very similar to that of benign prostate hyperplasia. There's an increased risk or incidence of urinary tract infections, urolithiasis, bladder enlargement can also happen. Those are just some examples. And the reason is really the same because of the pressure it's putting on the urethra as well as the bladder. Staging of prostate cancer has to do with Gleason scores, which you can see at the top. Now, Gleason grading system is a system of grading prostate cancer cells based on how they look under a microscope. And they can range from being very well differentiated, which means when you look at these cells, they look like prostate cells, all the way to, as changes occur, to undifferentiated, meaning that when you look at undifferentiated cells, if you didn't know that you were looking at prostate cells because it was indicated or you were told, then it would be very difficult to determine what organ these cells or what tissue these cells are a part of. Generally speaking, the higher the score, the more aggressive the cancer, and then the poorer the prognosis. You may have heard of PSA, or prostate-specific antigen. This is a marker for cancer, but it does not necessarily indicate cancer. Then that's an important consideration. In this image here at the bottom, this is showing us PIN, and PIN is prostate intraepithelial neoplasia. But the problem is most prostate cancers are diagnosed once they are invasive, and so it would be great if we could monitor during the PIN stage, but we're not able to do this quite yet. This slide here shows you the different areas that prostate cancer will preferentially metastasize to. And so I'd like to point out a few important ones here. So the lung, and really the pleura fits into that category, the bone, and the liver are very high in terms of the percentage metastasis to that area, but bone very high. So that's an important one I'd like you to be aware of when it comes to prostate cancer. And if you remember back in around 2010, Jack Layton, the leader of the NDP government, announced that he had prostate cancer. And although this is probably not entirely accurate of the whole story, he did have a sudden leg break, and I suspect, or it was suspected, that the prostate cancer had spread to bone. So whenever somebody has a sudden break of a bone where it doesn't really make sense, it shouldn't have really broken based on the injury that they had, it should make you think, well, what else is going on? A trip and a fall, you shouldn't fracture your femur that easily. So when you do, it makes you wonder if something else is going on with that bone, because its integrity has obviously been affected, but the question is, what has affected its integrity? The last cancer, male reproductive cancer, that we'll talk about is testicular cancer before we move on to sexually transmitted infections. Testicular cancer is most common between the ages of 15 and 35, so that makes you think it's really a cancer of the youth. And the most common type is a germ cell seminoma. Testicular cancer generally responds really well to treatment with up to a 95% cure rate. And it's easily detectable with a good self-exam. So reminder to all of you males that are listening to this lecture right now. Generally, it presents with a painless testicular enlargement. There can be a change in the shape of the testes. There can be swelling, or where it feels thicker in a particular area. There could be a firm, smooth lump. They are generally slow growing though, and that helps with its overall prognosis, but they also tend to come with this feeling of testicular heaviness that otherwise can't be explained. Now, a risk factor, and this is hopefully familiar to you, is cryptorchidism. So very important. Now, if metastasis occurs, let's say because it's caught too late and maybe it was left untreated, it can spread to the lymph nodes within the area. They're called retroperitoneal lymph nodes. And this is usually the first place for which testicular cancer will spread to, so behind the peritoneum. But it can spread if it gets into the lymph nodes and spreads from there. It most commonly metastasizes to the lungs and the brain. And at this point, this is when it becomes difficult to treat, like any cancer that's spread. So, good self-exam. Same with women and breast cancer. Okay, now let's move on to sexually transmitted infections, which will be our last handful of slides. Okay, on this slide, we can see the various types of sexually transmitted infections listed here, and we're going to break them up over the next few slides according to whether or not they're a bacterial sexually transmitted infection or viral. And so you're familiar with HPV, but we'll talk about that when we get to the viral infections. But you can see chlamydia, gonorrhea, and syphilis. Chlamydia, gonorrhea, and syphilis as being the most common types of bacterial causes of sexually transmitted infections. And although you don't need to know the numbers, and these are Canadian statistics from 2014, I would like you to be aware that for chlamydia, it presents with the most number of cases, followed by gonorrhea and then syphilis. So we'll start with the three most common bacterial infections being gonorrhea, syphilis, and then chlamydia will have a slide of its own. With gonorrhea, it's caused by the bacteria Neisseria gonorrhea, gonococcus, and it occurs in the endocervical canal and or the urethra. Now what's interesting about this condition, and we'll talk about this in more detail shortly, is the condition of pelvic inflammatory disease. The bacteria can ascend upwards in women and cause pelvic inflammatory disease. This condition of gonorrhea is usually detected earlier in males than females. And the reason for that is because of the mucopurulent discharge that's common with this condition. So this mucus discharge can be more easily identified in a male than a female. So a male's more likely to notice this before a female is. And all a mucopurulent discharge is this secretion of a fluid that contains mucus and pus. But this condition tends to respond well to antibiotics, which we know are designed for bacteria. Syphilis, the cause is Treponema pallidum. It's a spirochete. And what's interesting about this condition is these chancres form, but they're painless because this bacteria kills nerves, and so it can go unnoticed. And it progresses through stages. So we have primary, secondary, and tertiary. With primary, as already mentioned, you get this skin ulcer called a chancre that'll be found on the penis or the vagina. And these are painless, they're non-itchy, they're firm as well. And this stage can average upwards of about 3 weeks. Now, secondary, the ulcer disappears. So people will think, well, okay, I had this nodule, it's no longer there anymore, so I must be cured of this. But this is when this stage is when the bacteria becomes systemic, but it's still generally asymptomatic. Sometimes there can be a rash that's present on the hands and the feet, but otherwise asymptomatic. Tertiary, this is rare, but this is when it can travel to the brain. This is not common in Canada because of all the screening that is done. An important point to make before we move on to chlamydia is that congenital syphilis is possible. Congenital syphilis is a very severe, disabling, and even life-threatening infection that's seen in infants. Remember, congenital refers to something that you're born with. So this is a baby that's born with syphilis. And so a pregnant mother who has syphilis can actually spread the disease through her placenta to the unborn child. Now this is different than gonorrhea and chlamydia, which don't pass through the placenta and pass to the baby, but instead how they can infect the baby is during a vaginal birth. So when a baby is born vaginally, that's when they can become infected with gonorrhea and chlamydia. And that's where an ointment is put in the baby's eyes, regardless, unless the mother declines it, regardless of known history of gonorrhea, gonorrhea or chlamydia, in case the mother has it, to prevent infection of the eye, which is common with those conditions. And just a couple of terms to define here. Neurosyphilis, that's when it can actually be spread to the brain. And then gummas are soft, non-cancerous growths that result from the tertiary stage of syphilis. They're a form of a granuloma. Now, finally, in terms of the bacterial infections that cause STIs, we'll look at chlamydia. Chlamydia is caused by the bacteria Chlamydia trachomatis. It's similar to gonorrhea in that it affects the endocervical canal or the urethra. It can affect the urogenital region. It can lead to urethritis, so that can cause some urgency with some basic inflammation of the urethra that can lead to some urgency in these individuals, so they may not think much of it. It can ascend and cause pelvic inflammatory disease, just like we spoke of with gonorrhea. This is most commonly seen among young heterosexuals that have multiple partners. And for the most part, it's asymptomatic as far as what the patient would experience. But in viewing the cervix, you can see that it's very red and very engorged. Now we'll talk about the prevalent viral infections, viral causes of STIs. And genital herpes, human papillomavirus or HPV, and AIDS are the most prevalent. We've already spoken quite a bit about HPV and AIDS, but we'll do just a very brief review of what's relevant for this lecture. So with genital herpes, first what will happen is there'll be sexual contact that infects the individual. Then lesions will be noticed. These individuals will then oftentimes present to their healthcare provider. More lesions can form, but then the lesions start to heal and symptoms can be gone. And so these latent infections are common, and there'll be a period where these individuals don't have any symptoms. It's mostly caused by herpes simplex virus 2, which is different than herpes simplex virus 1 that is common with cold sores. And painful blisters will develop that lead to ulcerations. And it's pain that will usually quickly bring somebody to see their healthcare provider. Congenital herpes can happen as well. When this occurs, it's a child that's born with genital herpes if the mother's affected, so it can pass through the placenta. And with viruses such as this and HPV and AIDS, once you have it, you can't get rid of it. With HPV, remember that we spoke about how it can cause genital warts and cervical dysplasia, and we spoke quite a bit about cervical dysplasia and how types 16 and 18 can lead to cervical dysplasia, which could then lead to the development of cervical cancer. But it's strains 6 and 11 that you need to be aware of that can lead to genital warts rather than cervical dysplasia. And it can cause a condyloma, which refers to infection of the genitals, which causes the development of a benign mass. And then finally, AIDS. We've spoken about this before. As you know, it's a viral disease that passes on through various types of contact, but in particular sexual contact with an infected individual. We know it stands for acquired immune deficiency syndrome caused by human immunodeficiency virus. Okay, and one of the last topics to discuss is called pelvic inflammatory disease, which we've already spoken about briefly. We spoke about how with certain conditions such as chlamydia and gonorrhea, the bacteria can ascend and it can end up infecting the pelvic region of a female. And so it's defined as an acute inflammatory process of the female reproductive organs and the pelvic peritoneum. Specific organs that are affected with this disease include the uterus, the fallopian tubes, and the ovaries from this infection. So what happens is it can start as a cervical infection, then it can migrate upwards into the uterus, then it can continue upwards, so we're ascending. So hitting the uterus, then it can continue into the fallopian tubes, infect the fallopian tubes, and then it can make its way all the way to the ovaries, infecting them. So this is pelvic inflammatory disease. You can see here the terms endometriosis, salpingitis, oophouritis, and peritonitis. Endometriosis, obviously that's inflammation of the endometrium, so that's the uterus. Salpingitis is inflammation of the fallopian tubes. Oophouritis is inflammation of the ovaries, and then peritonitis would be inflammation of the peritoneum. This condition can be asymptomatic, but it can cause abdominal pain. Women can experience pain during sexual intercourse, so that's a consideration if a female complains of pain during sexual intercourse, and depending on what her other history might suggest. And complications can include infertility. There can be death from septic shock. Peritonitis, which is a term on the screen, is an important consideration because if there's an infected pelvic organ that ruptures, it can infect the abdominal cavity, which can be very much a problem and difficult to treat. So it'll start off as really one bacteria that causes this initially, but it can become polymicrobial, so many different microbes involved. And this image here shows you some examples of what this can look like. In this image at the top, you can see all of these adhesions that have formed. And as you could probably imagine, when the cervix is moved, as it can be with intercourse, then it can cause a lot of pain because there's less flexibility through here. A complication of pelvic inflammatory disease includes this condition here called pyosalpinx. So pyo referring to pus. So this is a condition in which the fallopian tubes can fill up and swell with pus. And this can come with further problems. So that is the end of not only this lecture, but the end of this course. I hope you all enjoyed it very much, and I wish you the best of luck.